Tom Hanks. And if you remember, I won't give the ending of the movie away, but Tom Hanks was marooned on an island after a plane crash, and first 15 to 20 minutes of the movie, he was unraveling psychologically because he had come to the conclusion that he was on this deserted island by himself, and the chance of rescue was pretty nil. And then what happened? Some debris from the plane crash washed ashore, and a volleyball, and I'll give Wilson a plug, but it was made by Wilson. It happened to be a volleyball that I used when I played beach volleyball pretty competitively for about 15 years when I was younger. Wilson became an object in Tom Hanks' life, and Tom Hanks, his emotional state stabilized because of other. And you'll hear me use this term a lot today in this webinar, talking about self and other. So to go back to the moon analogy, most of us would not survive. I would say probably all of us would not survive very long without other. If you look at some of the famous forensic cases of our time, specifically the Unabomber, who holed himself up in Wyoming, I believe, and had little to no human interaction with family or neighbors for that matter, and obviously became psychotic and did some horrible things. So when we look at borderline personality, this presentation is a brief, very quick summary of the field of object relations, which is a neo-Freudian psychodynamic term, and study of humans and their interactions with others. And what we're primarily talking about is the interaction with early phase development with caretakers, specifically mothers and fathers and the individual. The theory is based in fractures in relationships with self and other. Fractures meaning conflict, significant conflict. So how does that relate to what we see in addiction treatment? Now, I'll go on record to say that you're not most likely going to make a dent or heal anyone's borderline organization in a group environment in addiction treatment. However, if you think about some of the things I can pass on to you, they will certainly reduce the possibility of conflict getting in the way of someone's ability to get healthy or sober. So while you won't be really reforming anyone's personality in treatment with a borderline personality, you will certainly drop walls or not create walls that could prevent somebody from getting healthy. So hopefully that makes sense. And so let's talk about what happens between us, i.e. therapists, clinicians, counselors in addiction treatment in a group environment. What happens between us and the client? Now, I'll give you some cues. Carrie probably won't like this, but I'll give you some cues on how to pass the test when this is over with. So bear with me. But what is defined as self? Self is who we are, who we know we are, maybe not even who others know us to be, but who we know ourselves to be. That represents self. Other is can be a caretaker, can be an object, but remember, other is a representation of people in our existence. So when we look at this phenomena of projection identification, this is the reason, the main reason why individuals with borderline personality make it difficult for us to treat them in any milieu, whether it be addiction, whether it be inpatient psych, whether it be stabilization units, or in a private practice. Projection identification is one of the strangest, most bizarre things. However, bear with me, and I'll try to make it very, very simple. So when an individual with a borderline organization, typically what we see is that they are not aware of the emotional state that they're feeling. And the easiest way for them to experience that is through you, the counselor or the therapist. So I'll give you an example. Let's say somebody with a borderline organization, and this typically happens, is extremely angry and rageful. Yet they can't identify with that anger, nor can they identify with who they're traditionally angry at. So what happens is in consciousness, they split off and unconsciously put this anger onto us. And that creates what we call interpersonal pressure. So as a therapist in the group milieu, a borderline client will begin to challenge, will begin to stand up to, maybe confront, whether it be other group members or the therapist. And either the group member or the therapist will begin to feel the anger that the borderline client feels. So in a sense, what they're doing is, and it's fascinating to watch, not interesting to experience, but they coerce the therapist to either identify or experience consciously or unconsciously the feeling that has been projected. So I'll use anger, which is a common one. What will happen in treatment is the client will be talking about something and maybe looking at the therapist and talking about the way the therapist talks to them, the way the therapist interacts with them, the way the therapist sounds, and the client with the borderline personality will begin to interact with the therapist. And if the therapist is aware, and we'll talk about this, this is probably the key to this whole presentation, is you must be aware of your own emotional state. Now, real briefly, let's talk about our own emotional state. Who comes into this world, the helping world, unless we're a little bit, let's just say, unhealthy? This is a difficult field, and we all have a lot of grandiose ideas about helping people, but let's be honest, we have baggage. Everybody has baggage. So an individual or borderline organization is an expert at picking out and picking on our baggage. And they are experts in being able to elicit emotions from us. So the first thing you have to do if you have exposure to a borderline, either in group or in your practice, is totally be aware of your own stuff, your own pathology. And we all have it. There's nothing wrong with it. That's what makes us up. It's part of our self. But you have to be aware of what it is. And if you're not, I can pretty much guarantee you that somebody with a borderline organization will find it, exploit it, and expose it. So what happens with this interpersonal pressure is, as you're working with somebody with a borderline organization, they are going to coerce you into feeling what they want you to feel. That experience is called acting as if. So I'll give you an example. You have a client in group, and they've got a significant history of substance use. They've got a myriad of legal experiences. They've got witnesses to their addiction. There's data to support the DSM-5 criteria, but they don't want to hear about having a drinking problem or a drug problem. So they resist. And what they begin to do in their resistance is they begin to attack you. And you begin to feel angry. And you don't realize you're feeling angry, you just know you're feeling angry. So you can do one of two things when you're feeling angry. You can react, which is called acting as if, or you can understand your experience, your anger, and you can try to help the client understand what it's like to be in that moment with that client. And maybe that mirrors other experiences in that client's life where individuals get angry with them. So in other words, they're projecting their anger onto the therapist. Acting as if is when we get angry and we act as if we are the uninterested parent. We act as if we're the critical parent. We act as if we're the abusive parent. And it completes the circle. So this is why it's so difficult. Co-facilitation is probably one of the best ways to keep from acting as if when you see your co-facilitator getting engaged with somebody with a borderline. I don't mean engaged the way you might take that, but engaged in conflict with somebody with a borderline personality. The co-facilitator can help steer away from that engagement I'll give you an example, and when I do presentations, I am not afraid to talk about the mistakes I've made and the consequences to my mistakes. So here's one of my classic ones. I was working with a young lady from a very predominant family in Jacksonville, and she was an athlete in high school, went on to a Division I college for a sports scholarship, and decided to basically stray into her interest in drugs, hallucinogenics, and several other addictive substances, and basically just wasted her scholarship, came back to Jacksonville, and certainly through some psychological testing, found her to have what we call a borderline organization or a borderline personality. So in my work with her, I noticed in one of our interactions, I found myself getting very, very frustrated and very, very angry with her. And I have a rule in treatment that a client can say anything they want, anything that comes to mind directed toward me, that they can't get out of their chair. So safety is important. And this young lady, who couldn't weigh more than 95 pounds, got out of her chair and walked over to where I was sitting and got maybe 2 feet from my face and was saying things I haven't heard in years, since my hockey days in high school, I think. And I don't know what happened inside me. I do now, but at the time, all I remember is saying, "Get out." And I said, "Get out," with some emphasis. And she said, "You can't fire me. You know who my parents are." And then I said, "Get the blank out." And as she was walking down my hallway, I found myself saying, "Goodbye." And there was pleasure in my voice, and I had goosebumps as I was saying it. She got to the end of my hallway, walked out of my office, slammed the door. I don't know how she didn't break the glass. And I sat there for about 15 minutes, and I said, "What in the heck just happened?" Well, I said a little bit more strong language, but I won't use that today. But I just said, "What the heck happened?" And I had to stand and think about what I was absorbing. And what I was absorbing was not only all the anger and rage that she held, but her incredible ability to make me angry and not realize it was even happening until maybe 20 minutes after I reacted. So the story goes that she got home, her mother called me up and said, "I can't believe you threw my daughter out of your office." And I apologized to her. I gave her the money back for the session. I referred her to a couple people that I don't like. No, I'm kidding. But I referred her to a couple people and wished her the best, and then sat down and said, "How in the heck did that happen?" Well, acting as if, it's a fascinating phenomenon. So somebody with a borderline organization comes in, let's just say, in your assessment, you really need to pay attention to early relationships with caregivers. So typically a borderline will tell you who the parent is that they despised growing up, who they had conflict with. And what happens is, in the acting as if process, and this is amazing, you actually act as if you were their mother or their father. So they draw this anger and rage out of you, just like they drew this anger and rage out of their parent that they despise or cannot accept for who they are. So what ends up happening is we act as if we are their mother or their father. So what's important, and again, this is a broad brush, basic understanding of the interaction with the borderline personality, is you have to use yourself as a personal thermometer and be aware of your emotional state. And as a thermometer starts off at 0 and begins to work its way upward, don't wait until it's 110 degrees, in other words, right before you blow, before you realize that you're getting frustrated. So we'll talk more about how we can facilitate that later on. So what are common experiences when projected upon? Therapists, counselors, and other group members, you'll see this, have strong feelings of guilt. You'll see a group member typically feel sorry for somebody with a borderline organization. They feel sorry for the traumatic experiences they had growing up. They feel sorry for the less than optimal socioeconomic status an individual grew up with. You'll also see, and I know you see this a lot in group, you'll see individuals who have fantasies of rescue. And also, we clinicians have significant fantasies of rescue. That's what brings a lot of us into the field of psychotherapy. is we want to rescue our clients from their trauma and their pain. So when we look at these common experiences when projected upon, this is part of the emotional thermometer. So when you begin to feel sorry for somebody with a borderline personality, when you have thoughts of rescuing them, so what's some examples of rescuing them? Well, for female therapists with a female borderline, and typically about 98% of women or 98% of borderlines are female, you see when I supervise therapists, I see a lot of female therapists say they want to mother the individual with the borderline personality. They want to be the mother that was not there. And that falls into the category of fantasy rescue. You want to provide the mothering skills that were not there in development. You could see it as a nose on your face. That is part of the projection that an individual with a borderline personality projects onto the therapist to bring these feelings of rescue forward. They also bring in, boundary violations. It is very, very common for an individual with a borderline organization to manipulate in an extremely creative way therapists to cross boundaries, whether it be giving them extra time, giving them extra time in session, whether it be individual session in lieu of group, get an extra 15 minutes for a smoke break. There are a fascinating phenomena of how we cross boundaries mildly all the way to severely with individuals with a borderline personality. That drive or that desire inside us to cross these boundaries are part of the projection. You may be sensing that the patient with the borderline personality didn't have as many things as maybe you did growing up, so there's a desire to maybe give that person $5 for a pack of cigarettes or some money for food. Again, crossing boundaries, and we'll talk about how that backfires, and I'm sure you all know. Unfortunately, when you work with borderline personality, and I can only speak of in a private practice, is you become the sponge of rage and hate. And there's a phenomena in this projection identification process where you cannot absorb the rage and hatred. You have to help the person understand why they are rageful and hatred towards you. So if you absorb it, guess what's going to happen? You're going to act as if. You're going to give it back to them. And I don't mean to use this analogy right before lunch, but I've been told through feedback that it's very effective. If you can think of a borderline who has a very unstable base in their personality, it's very fractured and fragile, kind of like cement. It's very porous. If it's not solid, they vomit these strong emotions onto us. And at least I can just say in a private practice, the job is to spoon feed that vomit back to them and make it palatable. It doesn't have to taste good, but it's got to be palatable. The problem is, if you've ever been vomited upon, and I've got twin boys that are now 16, but I can remember the days where they did vomit on us quite regularly. Not many people enjoy being vomited on. So we act as if that vomit is disgusting. So that disgusting process is that giving back, that acting as if. So rage and hatred is very, very common with a borderline organization. And you can maybe this afternoon test this theory. There's a specific word that individuals with a borderline organization have great difficulty tolerating. And I'll give you a second to think about that, but it's a simple word, and it's only a 2-letter word. And I'm wondering if anyone can come up with it right now. And I'm sure half of you got it very quickly. The rest will laugh and they'll go, oh, it was so simple. The word no is a word that activates an inordinate amount of rage and hatred in a borderline organization. Now, you have to remember, if you go to attachment theory, a lot of individuals with a borderline organization have very disorganized attachments. They have difficulty getting their needs met. The problem with that is sometimes we're not aware of an individual with a borderline personality wanting to get their needs met, and we're not available to them. So they'll go to the nurse's station and say, I want to see my therapist or my counselor, and the nurse's station will say, well, your therapist is not available. In other words, the borderline will hear no. And then there's a rage and hatred projection. And let's be honest, nurses put up with an awful lot, and they're not going to put up with getting yelled at because their therapist is not available. And they act as if. I don't blame them. But this presentation, hopefully you can take back to staff and explain this projection process. I don't by any means suggest that we should be okay with being abused, but it's important to understand the rage and hatred and where it's coming from, and remember that we are just representations to the individual with a borderline personality. They may be angry with us, maybe being rageful toward us, but 95% of the rage and hatred is really directed towards someone that is outside of their consciousness or their awareness. Another projection identification process is helplessness and worthlessness, where an individual with a borderline personality, especially in addiction treatment, will present extremely helpless, meaning that they don't know where to go to a meeting. They don't have the confidence to seek out a sponsor. So what does that look like inside a therapist or a counselor? You'll see the therapist, or sometimes the group members, but predominantly the therapists, will begin to choose a meeting for them. They will find a sponsor for them. They will, without realizing the projection of helplessness onto them, they will act as if the borderline is actually helpless. So you will see things like, I'll get you a sponsor, I'll show you what meeting to go to, I'll get you a ride, God forbid, I'll take you there myself. Again, going back to boundary violations, we see this all the time, where the borderline has an innate ability to create helplessness in other people, i.e. the therapist, and then without awareness, the therapist or group members act as if the borderline is actually helpless or worthless. Now look what happens in this phenomenon. So let's just say that an individual with a borderline organization refuses to choose a meeting herself, and you've got the rest of the group saying, you can come with me. And the therapist says, no, Missy has to do it herself. So guess what happens? She shifts from helplessness to now the borderline has no worth. And the therapist just validated that. So what you end up getting is this rage and hatred, excuse my French, a shitstorm. And you look at each other, or you go back to your office going, I was just trying to help, I don't understand. Well, what we don't understand is, prior to this, maybe this presentation, is that the projection of helplessness is so strong, it induces us in a way to want to help crossing boundaries, help the individual with a borderline personality, because we actually think that is helping them. And you'll have to come up with your own answers on whether that is actually helping them or not. I come from the standpoint where I'm very, at least attempting to be very keen of the helplessness, worthlessness cycle, because it gets activated very, very quickly. Anxiety and terror is a projection where, if you look at the DSM-5 criteria, the last criteria talks about the potential for dissociation and paranoia. And these are feelings that the therapists feel, the anxiety and terror, that an individual with a borderline personality is going to do something. They're going to hurt somebody. They're unsafe. And this is the feelings that can get therapists in trouble. This is where, and I've seen this with a lot of younger therapists, where they give the cell phone number to their client. And they tell the client, if you're feeling this way, if you're in a night terror, if you're having a bad dream, or if you're in a conflict with a husband at home or significant other at home, or if you're anxious, call me. Well, there's several theories behind that, and I know the DBT model is very big on making phone calls and directing individuals to certain exercises, grounding exercises. But in the object relations model, that is perceived to be developing a dependency on the therapist and not necessarily helping the client deal with anxiety and the projection of anxiety and terror. So it's something to be aware of, again, when the therapist is beginning to feel terrorized or extreme anxiety, we do one of two things. We listen to it, we feel it, and we help the client understand it, or we act as if. This next experience is one that gets a lot of therapists into trouble. It's a topic that not many people talk about in the treatment of borderline personality, but I believe if you don't talk about it or if you're not aware of it, you're going to certainly fall into that trap, and that is erotic feelings and fantasies that individuals with a borderline personality have an incredible ability to project onto the therapist. Now, if you are a female therapist, and we've already talked about females predominantly having borderline organization, you can probably say, well, I'm heterosexual, therefore I'll make it pretty apparent to my client, and they won't project these erotic feelings or fantasies onto me because I'm just not that way. Well, individuals that have a borderline organization, I'm not going to say predominantly or half or most, but the numbers are pretty consistent that a large number of individuals with a borderline organization have been sexually traumatized, usually early in development. Now, I'm going to say something that might come back to bite me, and it's on face value, it's somewhat controversial, but listen before you react. When an individual is traumatized early in development, it is much more difficult to overcome than an individual who is traumatized later on in life, maybe in their mid-20s to early 30s. Now, I'm not by any means saying that it's not traumatic and it's not horrific when an individual is traumatized in their 20s or 30s. What I'm saying is that because we're precognitive and we really don't have the awareness when an individual is traumatized early in life, this is where the didactic relationship is absorbed into personality, into consciousness. That doesn't make any sense. At least an individual who has a healthy sense of self as an adult or a young adult can work through the trauma, whereas a child who's traumatized, they have much less capacity to understand what's happening. So what ends up happening as a young adult, whether it be a teenager or a young adult or even an adult individual with a borderline personality, is a huge part of their self is sexual. They've been sexualized, therefore they use sexualization as a language. They see themselves as sexual objects, and they see us as sexual objects. So it's not uncommon for a therapist to begin to have fantasies or erotic feelings toward an individual with a borderline personality. The problem is we don't want to admit it, or we don't want to recognize it, or even talk about it. So what ends up happening is, and obviously I think you can see that I'm male, and I'll say that most, if not all, of my clients with borderline personality are female. And there is this common dialogue that goes on with an individual, with myself, and it's interesting how a lot of discussion talks and directs itself towards sex. And I can use my thermometer, no pun intended, to help an individual know what is happening as they're projecting this sexualization onto me, or I can let it fester. And if it festers long enough, I will find myself having feelings toward this individual with a borderline personality. And if it goes too far, I could find myself fantasizing about the individual with the borderline personality disorder, and that detracts away from treatment. It gets in the way. The problem with erotic feelings and fantasies is that it's not wrong, it's not bad, it just is. But if you're not aware of it, it becomes problematic. So how does it become problematic? Well, you begin to treat the individual with a borderline personality different. You see them earlier, you let them stay in session longer, you spend extra time, you start sharing personal experiences with them, you start sharing your personal life with them. It becomes I would just say like a sexual relationship that's developed without it being sexual. Now, obviously the research and boundaries and professionals show that a lot of us unfortunately cross sexual boundaries with patients, And while I've not read any literature on it, I would bet that there is a percentage of individuals that male therapists cross sexual boundaries with. Most of the patients that they cross boundaries with may have a borderline organization. So when I do presentations in front of live people, I will ask people to raise their hand if they have ever had sexual feelings toward a patient. And it's amazing. I might get 1 or 2 people out of 100 that have the guts to raise their hand. And then I usually say at this point, the rest of you are lying. Thank you for those 2 for being honest. And of course, that brings a big nervous laughter. But it's a topic that nobody wants to talk about in psychotherapy. And in supervision, even, we are very leery about talking about erotic feelings. So the point I want to make is that if you are working with an individual with a borderline personality, don't be surprised if you begin to have erotic feelings or fantasies. That is the acting as if process, because an individual can project these onto you and you can help her understand it. But if you begin to react to it, you are acting as if you are the rapist, acting as if you were the traumatizing grandfather, acting as if you are the individual who just wants to use her for a sexual object. So you have to be very, very careful. And again, this goes back to having great insight into your own, I will say, pluses and minuses. You know where your strengths are, and you hopefully know where your weaknesses are. We can talk more about that in the second presentation. So what do we do with it? Be aware of what we are being driven to do. In other words, I've heard this so many times in supervision. I just want to be her parent. I just want to be the mother that she didn't have. And to me, that's like chewing on tinfoil, because that is the process of projection identification. When a therapist wants to protect a patient, and let's just be honest, if you do the work that I've done over 20 plus years, there are fantasies of wanting to murder your patient. That's half tongue-in-cheek, but it's not. When it comes into really getting into this process of projection identification, I mean, there's a lot of therapists that, at least in this area, refer to me because they just cannot tolerate working with the emotional spectrum that goes on with working with borderline personality. So they have the innate ability to project this love and hate phenomena onto us. In a treatment center, you see this all the time. A therapist will go to staff and begin warning staff about the individual with the borderline personality. The unfortunateness in today's healthcare system is that sometimes staff have no patience with individuals with borderline personality, or they're not trained to work with a borderline personality, so they think tough love is the best answer. I'm not here to educate staff, but I can say that if you think about this phenomena of projection identification, just be aware of it, you can treat the individual with a little bit more of a clinical set of kid gloves than just acting as if you are the critical parent or the abusive parent. So what do we do with the wish to have sex with our patient? That's the last, number 5. What do we do with this wish to have sex with a patient? Well, you get a couple of choices. You can have sex with your patient and think that there's not going to be any consequence and then blame the borderline patient to the Department of Health in your particular state. And I can just tell you that in the state of Florida, that doesn't go over very well. It's not much of a defense. Or you can use in your own mind, how can I use this projection of her wanting to have sex with somebody that she's getting close to, i.e. a therapist. So this is where I usually have a huge slide that says stop. Get a hold of yourself, because you're about to act as if. You're about to act as if you're the last 11 boyfriends she's had in the last 35 days. You're about to act as if you are the perpetrator early in her development. You're about to act as what she believes is the loving object, and you will find out that if you were to have sexual relations with her, you would have to break it off most likely, and then you're going to experience an incredible emotional storm. So if you're beginning to feel sorry for her, another interaction, another projection identification trap. making her, one, to make her feel special. Telling things like you are special, you are a special person. While we think that is helping an individual, that's actually acting as if you are that caretaker that she never had. Another example is giving her extra reading time, extra dessert, extra smoke break, no pun intended, extra Klonopin, money for a bus ticket. We see this a lot, or at least I've seen this a lot over time, where medical staff likes to provide the benzodiazepine class because it's sedating. Unfortunately, that can be extremely reinforcing and creating that dependency not only on the substance, but creating a dependency on that provider of the substance. Another example of acting as if is responding in a way that leaves her feeling worthless and untreatable. You've heard us a lot of times that borderlines are untreatable, and I can tell you that I've made a very healthy living, and I hope I've made an impact on some of my clients' life, but I certainly believe that individuals with a borderline organization are treatable. And I say this to the younger male therapists out there: if you flirt with an individual with a borderline organization, you're going to get in over your head very, very quickly. And it usually comes to awareness when there is an experience that you can't explain to your supervisor, and it looks really bad, but it was just casual, innocent flirting. Sexualization is a common theme with the borderline organization. You have to be extremely careful. So what's a reenactment? A reenactment, again, if you sit back and look at this, a reenactment is an experience. Well, let's look at an act in a play. If you've ever gone to a play, and maybe you've gone to that play twice, and you've watched the play 2 or 3 different times on different nights, you will see commonalities from last night's performance, and you'll see maybe some changes. But for the most part, it's the same play. Or a reenactment is an experience or a dyad that goes on between the borderline and a other in her life. So I'll give you an example, a simple example. Let's just say that a mother was extremely rejecting and the individual turned to substances in lieu of getting therapy. So they present at your facility with a horrible experience in their development with their mother. And they describe their mother as very rejecting, very cold, and very critical. So during your assessment, the phone rings 7 times, your cell phone goes off 3 times, and somebody comes in and asks you what you want for lunch while you're assessing her. So she gets upset, and you slide it off and just say, well, I've got to eat lunch. Well, what part are you playing? You're playing the role of the critical parent. You're playing the role of the non-loving, non-caring parent right off the bat in the assessment. Now, I'm not saying that these things aren't normal part of life and normal part of treatment, but you have to be aware that when the borderline is reacting to you, that it's most likely a reenactment that's outside of their awareness. I will talk at the next presentation that I give about how to softly create or attach the here and now to the past. There's a drive in us that wants to say, well, I'm not your mother and, I'm here to help you. Unfortunately, that doesn't work. So you have to ask yourself in this interaction, what part am I playing? Now, it is very, very common. I've seen this a million times, and I've probably done it 100,000 times myself, and that's we deny the role that we play in the interaction. We intellectualize and rationalize that we're trying to help, that we're not part of this, and it's all on the borderline. So we blame her because she's borderline, this is what she does. And that's not fair, and you're certainly going to impede that person's ability to get healthy in their treatment. So you have to ask yourself, what role am I playing? And commonly, I'm not going to say 100%, but commonly you are the rejecting, denying of love, withholding of love object that is stuck in consciousness. So, for example, if an individual with a borderline personality comes to you about 4:45, you're tired, it's Friday afternoon, you want to go home, and they come to you and they say, can I talk? Well, you're at a crossroads. You want to go home, you've got plans with your family, you want to just go home and relax, but you also are an altruistic therapist and you want to provide maybe a little bit above and beyond for this person because they're in pain. So what happens? You're stuck. You're in a classic double bind. Darned if you do, darned if you don't. So you stick to your boundaries and you say, our week is pretty much up. I'm leaving in 15 minutes. I'll talk to you Monday morning. And they have a emotional reaction. Let's just say a rageful reaction. That's one experience. The second experience is you stay till 9:15, listening to the borderline talk about the nurse that is uncaring and the two people in group that don't like her, and you get kind of stuck into this myriad of drudgery. And what ends up happening is, while you believe you're helping, what really ends up happening is you're validating her worthlessness, but you're validating her ability to manipulate and not set a healthy boundary. When we try to set healthy boundaries, we usually get an emotional experience at first. So have to ask yourself, geez, it's 4:45, I stayed till 9:15, what role did I just play in this reenactment? Well, this is where the manipulative part of the borderline plays a piece and the sexualization part of the borderline plays a piece. Have to be very, very careful to what you're experiencing with regards to that internal thermometer. So here's the part that it takes. I supervise some registered interns and supervise some therapists that want to get a little deeper into treating borderline personality and trying to convince therapists that we play a part no matter how we react, whether we like it or not. And I go back to that Tom Hanks experience, or the moon analogy. When you have two objects, there are interactions going on between those two objects, whether we like it or not. Just being in a room and here and now with an individual with borderline personality, we are playing a role in that reenactment, whether we like it or not. So to deny that we play a role, or to deny that we don't play a role, is not going to help the situation out a whole lot. So simply ask ourselves, what role am I playing right now, is extremely important. So the other part in the treatment of working with borderline personality in a substance abuse environment is to accept that you're not going to heal a borderline organization. You're not going to heal that. What you're going to do is hopefully lower the walls that impede an individual getting sober or getting healthy. So it's trying to reduce the amount of conflict that goes on in a treatment environment. Now, the difficult part with that is you might be able to control yourself, but how do you control other group members? And that will be a part that I will focus on in the second webinar, is how you can use the group environment to be the other for the individual with a borderline personality. I hope that makes some sense. So let me go back and summarize real quickly. Going back to the original slide, the very first slide is the difference between us and the client. Projection identification is when an individual splits off an unconscious emotion onto the therapist or a group member, and that group member or therapist feels what has been split off and feels the magnitude of what's been split off. And they have basically two options. They can act as if, and they can get angry back at the borderline, or they can understand that this is what the borderline is feeling and not able to identify it, and more importantly, not act as if. And I just use the example. It's my own personal thermometer. And if you can just feel the emotions that you experience working with this borderline, as the emotions are increasing or decreasing in you, you can at least stay one step ahead. And that's the goal in working with somebody with a borderline organization, is staying one step ahead. Common experiences when projected upon are feeling guilt. The drive to rescue is what I see the most. The drive to want to make it better for the individual with a borderline personality. Now, let me go off for a second on hugging and touching in treatment with an individual with a borderline organization. this is my own personal bias, but I refuse to touch or hug an individual with a borderline experience. You may see that differently. I know there's a lot of hugging in addiction treatment. The problem with that is individuals in group never know the complete sexual history of an individual that they're hugging. And unfortunately, with the borderline organization, we know that a lot of individuals are sexually traumatized and don't have sexual boundaries. So the intention of the hug might be something that is well-deserved and positive, but how that hug is being received can never totally be acknowledged. And I just ask that you think about that, and I think that unfortunately starts a slippery slope of projection identification when it comes to erotic feelings and fantasy. The hug starts it. So I'm from the notion of if I get the mindset that an individual is going to hug me, I stick my hand out faster than I can so that I'm not put in a position to hug. And then if it comes to it, I'll tell a client that I don't hug them because I have no way to know how they're going to take that. Some of you may feel totally different about that. That's okay. This is my own personal bias, but I want to go on record to say that I have not been sued or had a complaint filed against me for sexual misconduct with individuals with borderline personality. So it's something to be very, very aware of. And again, we talked about the rage and hatred. And the phenomenon in object relations is called letting it pass through you. So an individual is yelling at you, screaming at you that you're not caring, that you're not loving, that you shouldn't even be a therapist. You're to let that pass through you. That's what makes it difficult to work with somebody with a borderline personality, because not many of us like to be raged upon or yelled at. So these are all experiences of projection, anxiety, terror, and like I talked about in length, the erotic feelings and fantasy. I could probably do 6 hours of talking about erotic feelings and fantasy because it's very, very common with a borderline organization. What do we do with it? We're totally aware, hopefully we're now aware of this drive to want to parent, to protect, to do harm to warn staff, or to have sex with. And I've always said to individuals that if you're having these thoughts and feelings, go to somebody who is knowledgeable of working with a borderline personality and are knowledgeable about projection identification, so you don't do damage in treatment and you actually can reduce the walls between you and an individual with a borderline organization. So this acting as if process, and there are several of you probably smiling or laughing internally going, oh my God, I've probably acted as if a lot of times. Well, that's okay, because it's a learning process. It's an extremely complicated process, one that you will fail at miserably for a long time before you actually can get ahead of an individual and their projection identification. And then the reenactment. And again, this is a basic broad brush, but what I see a lot at treatment centers is the reenactment goes on with ancillary staff. They either get kind of sucked in and want to give a little extra time, give them extra smoke break, give some extra food, or they react negatively toward that individual with the borderline organization and impede the person's ability to get sober. So again, this is more about insight and understanding from our perspective, and once we get that understanding, we can certainly help the individual get focused on what is more important.
So with that, thank you so much. That was incredibly informative. And hopefully you all are able to take some of that and use it in your practice. We do have a couple of questions here. Wendy asked, so people with BPD avoid their feelings and learn how to disconnect because the caretaker they despise was avoidant with them, correct?
That is one great summary of one of the theories, and there are several theories of the creation of a borderline organization, but that is commonly seen as lack of attachment with a parental caregiver. So I will say yes, possibly. Again, working with an individual with borderline personality, probably the most important piece is the assessment, and that is looking at in depth their relationships with caregivers, important people in the first 5 to 7 years of life. And you will see these potential reenactments that are created in your assessment. You will see them explain that their caretakers were cold, they didn't provide love. And remember that a lot of their caretakers had probably severe substance problems themselves. So there's a recreation and a reenactment there. But that's a very good summary of some individuals with a borderline personality. I'm not going to say all because it's so complicated, but that is a great summary of some people with a borderline organization.
Fantastic. Next question, and a reminder, if you have a question, please put it in the question box in the right side panel of your screen. Do people with BPD tend to be more narcissistic as well?
There's, again, several theories. What we see a lot of, Otto Kernberg does a really good job of explaining that males suffer from narcissistic personality disorder spectrum because of the same reasons, lack of attachment and lack of connectivity with caretakers. Borderlines typically are female and they have the same issues with attachment. They deal with them differently. So you do see people with borderline organizations sometimes also have narcissistic traits, but we have to remember too, narcissism is the love of projected self, not necessarily overconfidence or haughtiness or cockiness. It's really the love of projected self. So sometimes I see people get the term narcissism confused, but certainly those traits go hand in hand at times with individuals, making it much more complicated and difficult to treat.
I work with the population of adolescent girls. Is there any difference with BPD with age?
What we see a lot is, I get this question a lot. Personality is argued to not be completely developed until the late teens, early 20s. So you will see an individual generating what you think are or is a borderline organization. And I'm certainly not a predictor of the future, but I think you can certainly see the love-hate experience that goes on with an individual, an adolescent, with maybe the early development of a borderline personality. I would suggest that you do some reading or some studying in the attachment area to increase her attachment to caregivers. But I think it's a crapshoot to, I would never attempt to predict whether somebody is developing a borderline personality, but certainly I think there are patients that stand out that you know are creating this dyad of interaction with individuals. The problem with, as you know, if you're working with adolescents, and I thank you for doing that so I don't have to, because I've got, as I said, twin 16-year-old boys, the lovely phenomena of hormones. So the hormonal development and your typical teenage development can certainly look like somebody's developing a borderline personality when really it's just normal part of development. So I'm not even sure that I'm qualified to answer that question adequately because of that conflict. But it's a great question, and the research out there is all over the place. But I like to remember that individuals that are in that adolescent stage are in a stage of hormonal development that can mirror a borderline personality, and that doesn't necessarily mean that they are developing one.
Last one, is it recommended that females work with these patients?
A great question. I come from the school of thought that it doesn't matter, but I will say this. To activate the transference that goes on between an individual with a borderline organization, what better place for there to be a male object as a therapist if the perpetrator or the person that created a conflict is male? And if an individual has sexual trauma as a history, they will typically ask for a female therapist. I'm from the school of thought that it doesn't matter as long as you're aware of your own countertransference or your own reaction to the projecting identification. But I will tell you that doing this 20 plus years, I get accused all the time of coming to work with an agenda to activate this projection identification process. And I can tell you, on a stack of Bibles, I will say I have never spent time thinking about activating it. It just happens. So I think it's open to what you want to do, but I'm not restricted to male or female, I don't believe.
All right, that's it with this presentation. We really thank you for joining us today, for taking an hour out of your day to spend some time with us and learn about personality disorders. Like I said, Michael will be back with us in June to do part 2 of this. We will send the follow-up email that has the evaluation and the post-test. So please watch your email within the next 60 minutes for that and complete the evaluation so that we know if you got a lot out of this and other topics that you might be interested in learning about in the future. And have a great rest of your day. Thank you.